Hi folks, welcome to my channel, The Average Dermadoc. Let's begin the show.
Antihistamine. What is a histamine? It is a biogenic amine. What does this word biogenic means? It means which is synthesized inside a living organism. Here our histamine is a biogenic amine produced from histidine by the enzyme histidine decarboxylase inside mast cells. Clear, mast cells produce and release histamines. These histamines are culprits in acute and chronic urticaria, angioedema, and acute insect bite reactions, and also in cutaneous mastocytosis. Hence, our antihistamines can be used in all the diseases where histamine is acting as a culprit. Coming to stimulators of mast cells. There are immunological and non-immunological factors which stimulates mast cells. Coming to immunological, it is IgE, anti-IgE autoantibody, IgG, anti-FcER1 alpha, complements like C3a, C4a, C5a. Under non-immunological stimulator of mast cells, substance P, stem cell factor, salicylates, NSAIDs, and neuropeptides. There are so many drugs and foods which stimulates mast cells. Hence, there are so many stimulators of mast cells. Our antihistamines won't stop mast cell from producing and releasing histamine. They only blocks the effect of histamine in the body once they are released from the mast cell by antagonizing at the receptor level. What are histamine receptors? There are 4 types of histamine receptors in the body. Coming to first receptor, histamine type 1 receptor. They are present in smooth muscle of bronchus and intestine. Hence, they cause bronchoconstriction and constriction of the intestinal smooth muscles once they are stimulated by histamine. Then they are also present in sensory nerve endings of the skin. 85% of the histamine receptors are present in skin or H1 receptors. Only 15% of histamine receptors in the skin are H2. Hence, we will rely mostly on H1 antihistamines in the treatment of urticaria. They will cause itching, axon reflex flare. H1 receptors are present in CNS, which are responsible for wakefulness. Hence, the reason for sedation when we give antihistamines is blockage of these H1 receptors in the CNS. When they cross blood-brain barrier and reaches the brain, they will induce sleep because they are blocking the wakefulness effect of the histamine. They are also present in endothelium. Here they will cause vasodilation, which is responsible for erythema, and they will also cause increased permeability, which is responsible for edema. In urticaria, we will have clinical lesion called wheal. What is a wheal? Wheal is nothing but triple E, evanescent, erythematous, edematous plaque. Evanescent means transient, that means it is short-lived. Edematous reason is here because of histamine stimulating H1, H2 receptors. There will be increased permeability leading to edema, and then erythema because of vasodilation. All these are due to stimulation of H1, H2 receptors by histamine. What is wheal? It is an evanescent, erythematous, edematous plaque. Next, H2 receptors, same, they are also present in skin, endothelium, same action, but they are, in addition, they are also present in parietal cells of gastric mucosa. Their main action here is acid secretion. Hence, we can give H2 antihistamines to treat peptic ulcer disease and GERD. H3 receptors are present in presynaptic neurons, which is responsible for negative feedback. H2 receptors are also present on mast cells. They also have some negative feedback. H4 receptors are present in mainly immune cells along with mast cells, T cells, eosinophils, neurons. Their main mechanism of their action is chemotaxis of immune cells. Mainly we have to know about H1 receptor and H2 receptor. H3 and H4 antihistamines are still at research level. Coming to H1 antihistamines, what is their mechanism of action? They are inverse agonists of H1 receptors. What do you mean by inverse agonist? What is the difference between antagonist and inverse agonist? Suppose there are agonists which stimulates H1 receptors. If we give antagonists, they will just block the action of agonist. That's it. For suppose if we give inverse agonists, they will not only block the action of agonist, they will also work exactly opposite to that agonist. That is inverse action. For example, take H2 receptors. They are responsible for secreting acid in response to histamine. If we give antagonists, they will block the response to histamine and they will block secretion of acid. In the same case, if we give an inverse agonist like our H2 antihistamines, they will go and block the action of histamine. There won't be any histamine induced acid secretion, but also they will inverse action. They will show inverse action, that is exact opposite action. They will reduce the secretions of acid in H2 receptors that will be there independent of the histamine. Even in the absence of histamine, this inverse agonist will reduce the secretion of histamine. That is exactly inverse action to the agonist. Clear? Antagonist just blocks the action of agonist. Inverse agonist not only blocks but also acts inverse to that of agonist. If in the presence of histamine, there will be more and more acid secretion. In the presence of inverse agonist, even in the absence of histamine, acid secretions will be blocked. There are two generations of H1 antihistamines. Coming to first generation, these are ethers based on imidazole ring structure of histamine. They are lipophilic, hence they will cross blood-brain barrier and blocks the effect of histamine, that is wakefulness. Not only blocks, because they are inverse agonists, they will induce the exact opposite action, inverse action, that is they will induce sleep, that is sedation. That is the reason for sedating effect of H1 first generation antihistamines. And they will also block acetylcholine receptors, leading to antimuscarinic side effects, also known as anticholinergic. They are acting against acetylcholine. That's why these side effects are called anticholinergic side effects. Will be more in first generation H1 antihistamines. What are the examples of anticholinergic or antimuscarinic side effects? Acetylcholine is responsible for all the secretions in the body. Now we are doing opposite to that. We are reducing the secretions, making them dry, like dry eyes, dry mouth, urine retention, constipation. All these will be more in first generation. To avoid all these sedating effects, antimuscarinic effects, we have chemically modified derivatives of first generation antihistamines. That is nothing but our second generation antihistamines. We have made them less lipophilic, so low sedating, and they are very highly selective only at H1 receptors. They won't touch acetylcholine receptors. That's why there will be less antimuscarinic side effects. Somewhat safe without any anticholinergic side effects. This acetylcholine helps in digestion. It is responsible for parasympathetic activity. If we are blocking parasympathetic activity, there will be stimulation of, there will be no balance between parasympathetic and sympathetic. So there will be stimulation of sympathetic activity, leading to increased heart rate also. In case of first generation H1 antihistamines, what are the examples? A, P and E. A for alkylamine. Example, chlorpheniramine maleate. That is nothing but CPM. We will call it as Avil. It is a pregnancy category B drug. All the pregnancy category B drugs can be given safely for pregnants. Available in tablets 4 mg, 12 mg, syrup CPM, and injection avil. When we go to DRP in peripheries, there we will be giving this injection avil, just like chocolates on Independence Day. There the people will be celebrating Independence Day daily because they have the freedom to come force us to write injection avil. Until we write this injection, they won't even move an inch. What we can do? We can't avoid prescribing this injection. At least we can caution them not to drive back home because they may feel drowsiness after getting this injection, as this first generation antihistamines crosses blood-brain barrier and inhibits histamine effect, that is wakefulness. Not only they inhibit wakefulness, as they are inverse agonist, they will induce sedation. So the least we can do is caution them not to drive on their own back to their home. Anyway, we can't avoid prescribing injection avil. Next, P for piperidine. Example, cyproheptadine. It is also category B, available in tablet syrup. Except cyproheptadine, every other first generation antihistamine have tablet formulation, syrup formulation, injection. Here cyproheptadine won't have injection formulation. Piperazine. Example, hydroxyzine. It is category C, available in injection, tablet 10 mg, 25 mg, 50 mg, and syrup. Syrup attracts tablet. We must have heard that is nothing but hydroxyzine. Next, P for phenothiazine. Example, promethazine. It is also category C drug, available in same injections, tablets, syrup formulation. Last class, E for ethanolamine. Example, diphenhydramine. We all must have heard syrup Benadryl. That is nothing but diphenhydramine, available in injection, syrup. One extra thing is it is available in topical formulation also. Whenever a patient comes with urticaria or wheal, we will prescribe both oral antihistamine, either first generation CPM or second generation cetirizine, and topical antihistamine, this diphenhydramine, which is present in calamine lotion. What is the difference between calamine lotion and calosoft? Calamine lotion may contain this topical antihistamine diphenhydramine, and it will have less moisturizing property, so it will make skin dry. Whereas calosoft, name itself indicating, it will have soft liquid paraffin, more moisturizing effect, and it doesn't contain this antihistamine diphenhydramine. Cooling agent calamine will be there, which will work in reducing itching. All first generation antihistamines almost reaches peak within 2 hours. They are metabolized in liver by the enzyme CYP3A4. So they will have more drug-to-drug interactions. Whatever the drug is inhibiting CYP3A4 will increase the levels of our first generation antihistamines. Coming to second generation antihistamines, these are nothing but derivatives of first generation. So derivative of alkylamines is acrivastin. Derivatives of piperidine, loratadine, desloratadine. Desloratadine is active metabolite of loratadine. This arrow mark indicates which drug is active metabolite of which drug. Here levocetirizine is active metabolite of cetirizine. Already they are active metabolites derived from first generation drugs. So here they won't undergo much of metabolism in liver by CYP3A4 enzymes. So drug-to-drug interactions will be less in case of second generation antihistamines like cetirizine, levocetirizine, loratadine, desloratadine, fexofenadine, rupatadine, avastin, bilastine, mijolastin. Piperidine class finish. Next, piperazine. Cetirizine is nothing but an active metabolite of hydroxyzine. Levocetirizine is an active metabolite of cetirizine. Some second generation antihistamines are not derived from first generation antihistamines. They are entirely separate structures like olopatadine, agelastin. Both are available in nasal sprays and eye drops formulation. For allergic rhinitis, allergic conjunctivitis, we can prescribe this antihistamine second generation nasal sprays or eye drops. From this table, we can write whatever antihistamine we want, some points. If you take, for example, CPM, we can write which category does it belong, what is it, ether, based on imidazole ring structure of histamine. It will produce sedation and it will have antimuscarinic side effect. Like that, from this table itself, we have to derive as many points we can and write in our exam. No need to study separately individual drugs. Coming to H2 antihistamines, H1 chapter finish. First generation, second generation. Coming to H2 antihistamines, these are also same inverse agonists of H2 receptors. What H2 receptors will do in gastric parietal cells? Acid secretion. This inverse agonist not only blocks histamine-induced acid secretion, they act inversely, exact opposite action. They will also inhibit secretion or production of acid even in the absence of our histamine. They are powerful CYP enzyme inhibitors, so they will have drug-to-drug interactions. They will increase the serum levels of beta blockers, calcium channel blockers. At high concentration, they even cause CNS side effects like drowsiness, dizziness, confusion, headache. All these will be seen at high concentrations only. What are the examples? Cimetidine, ranitidine, famotidine, nizatidine. So, while treating urticaria patient, we can combine H2 antihistamine with H1 antihistamine. Coming to cimetidine, it has some special properties. It has antioxidant property and has more anti-androgenic side effects when compared to rest of the drugs. Cimetidine has more anti-androgen effect like gynecomastia, decreased libido and sperm counts in men, galactorrhea in females. It increases the levels of, as a CYP enzyme inhibitor, same like other H2 antihistamines, it will also increase the levels of SSRIs, antiarrhythmics and metformin. While prescribing H2 antihistamines, we have to keep all these drugs in our mind. Beta blockers, calcium channel blockers. Coming to doxepin, it is a tricyclic antidepressant with potent H1 and H2, both H1 and H2 antagonism property. It is 800 times more potent than diphenhydramine at the level of H1 receptor. So it will have more sedation. Available in oral and topical. Both these formulations cause sedation as they are more potent. What is the most potent antihistamine? That is doxepin only. They will have more sedation effect, more antimuscarinic side effects. Oral tablets are category C, topical formulations are category B. Both are contraindicated during lactation. We are not allowed to prescribe topical doxepin also for during the period of lactation. Avoid doxepin in glaucoma patients as they increase intraocular pressure and also with monoamine oxidase inhibitors. We will know a little about cetirizine. It is a carboxylic acid metabolite of hydroxygen. I have already told you it is an active metabolite of hydroxygen. Hydroxygen is a first generation, cetirizine is a second generation. It reaches peak within 1 hour and suppresses histamine-induced wheal in 20 to 60 minutes. That is, within 1 hour it starts its action. And this effect can last up to 1 day. Reaches peak in 1 hour, shows its effect in 1 hour, lasts its effect in 1 day. With t-half of 8 hours, a steady state plasma level is achieved only after 3 consecutive days of administration. After 3 consecutive days of administration, plasma levels will be stable. There is little to no tolerance after repeated doses. What do you mean by tolerance? Suppose we are prescribing the same drug, the same dosage for a long period of time, the therapeutic response, the desired effect will become reduced. This is called tolerance. Then what we have to do, there will be a need for increasing the dosage to get the same level of desired therapeutic effect. As with cetirizine, there is no tolerance. We can give the same dosage of drug for a long period of time. No need to increase the dose until otherwise the disease severity increases. Then there may be need to increase the dosage of cetirizine. It is not significantly metabolized in liver. I have told you the reason. It is already an active metabolite. They won't undergo significant metabolism further in the liver. So less drug to drug interactions. Excreted unchanged in urine. So no need to adjust dosages in liver disease patients. There is need for adjusting patients. There is need for adjusting dosage only for renal disease patients. Cetirizine also inhibits eosinophil accumulation in tissues. What are the drugs which are safe during breastfeeding? I already told you doxepin. We can't prescribe doxepin during lactation. Then what we can prescribe? We can prescribe cetirizine and loratadine safely during breastfeeding. What drugs we can prescribe during pregnancy? All the category B drugs present here in this table are safe to prescribe in pregnancy. If we want to induce sleep, we can prescribe CPM. If we want to give less sedating drug, we can prescribe cetirizine. Both are category B drugs only. H1 antihistamines may be beneficial in atopic dermatitis patients with allergic rhinitis, allergy-induced asthma, as H1 receptors exhibit high degree of plasticity. Plasticity means adaptability in response to diseases like inflammatory diseases, atopic dermatitis, and in response to drugs, they will adapt themselves. Like for example, there will be increased H1 receptor expression in nasal mucosa in allergic rhinitis patients who are already having atopic dermatitis. Our H1 receptors expression will be more in the nasal mucosa. So we can use H1 antihistamines for treating allergic rhinitis also, because the culprit there is nothing but histamine and H1 receptors more expression. We have to know what to counsel the patient when they come for us and ask a doubt, what foods we have to avoid in case to avoid wheals that are histamine rich foods. We have to counsel each and everything here to patient. Mainly alcohol, red wine, beer, chocolates, mainly black chocolate, tea, mainly green tea. That's why I have written tea in green letters. Coffee, tea, nuts, fermented food, mainly aged foods like curd, yogurt, all these, if they are freshly fermented, there will be low histamine. They are fermented for a long time, they will contain more histamine. Seafood like prawns, shellfish, processed or preserved meat like smoked meat stored for a long time in deep fridge, we have to advise them to eat only fresh meat. What they can drink here? Alcohol not to be taken, tea, coffee not to be taken. They can drink water, fresh milk, because curd is a fermented product. They can drink fresh milk, coconut water, vegetables and fruits like tomato, brinjal, spinach, especially this brinjal. Every patient will be asking whether I can eat brinjal or not. It is a histamine rich food, we have to avoid. Banana, citrus fruits like lemon, orange, strawberries, cherries, pineapple and papaya, all these they have to avoid. Egg white and some spices like red chili powder, green chili powder, paprika, all these will stimulate mast cell to produce histamine. It is important to advise without forgetting any of this food to the patient, because it will help us to revise also. No human can remember all these foods by studying once. We have to practice by counseling the patient Each time we counsel, we will get a chance to revise what are histamine rich foods. It will help us in paper 1 question also, diet and dermatology. Remember the channel name. Don't forget to like, share and subscribe. Thank you. Hasta la vista. До свидания.